we wear shoes, right? Because that's easy. Of course we're going to wear shoes. But when we say things like first do no harm, we think that that sounds very simple, and it is simple. It's just not easy. So we're going to talk today about some of the terminology we use, because this gets us tripped up a lot, and really talk about the importance of the interaction. I tend to get a lot of talks about non-mainstream emergency medicine topics. I mean, I've even given a lecture on tattoos and piercing emergencies, and I don't know why I get these talks. Like, I know science too. I can talk about pediatric sepsis, but I never get the pediatric sepsis talk. I get transgender patients in the emergency department, which is great. But it's a little softer. But I will say that the softer side, the humanities side of emergency medicine, is as important as the medical science side. And we know this because as much as we've moved our science forward, what we're doing is we're leaving behind people that we're not connecting with, or people who are marginalized, more and more. And that goes back to an earlier talk today about health equity and how we provide healthcare services and who trusts us. And the transgender community is definitely in that group of individuals in whom we have not engendered a great deal of trust, and that has profound impact on health. So we're going to talk about that a little bit, and then we're going to get to some of the nuts and bolts about medical treatments and surgeries, and talk about that. So everybody has very different feelings about this, okay? And that's fantastic. We're all different humans. We should have different feelings about this. My general assumption, and I don't poll people because I'm not sophisticated enough to do it everywhere, nor do I want to put anybody on the spot by having them raise their hands, but my suspicion is that out of a group of 100 physicians, maybe is not a cisgender individual. Maybe 5 to 10 people are advocates of the trans community or the non-cisgender community. Not that it's a community like we think of, but you know, a group. There's about 5 to 10% who say, I can't. Nope, the way that I view the world, this just does not compute, and I'm just going to struggle how not to let that be in the way when I'm taking care of people. And that leaves the other 80 to 90% of us, who I think are probably in one of two camps. You can nod if this resonates, or if you agree with me. You can shake your head if you're like, you're full of it. But the two camps are, I understand this is important. I understand this is a thing that we need, that is becoming more talked about, more aware of. I understand, and I want to be better at it because I believe that there's, hey, my name is Stephen, and I go by he, his. Then you say, okay, hello, Stephen, right? Like, that's step one. That doesn't seem to be very harmful to anybody. I think most of us would like for people to address us and interact with us in the way that we would like. So it's understanding that gender is really not, binary gender is, I'm not talking about biologic sex here, right? But gender, how we express, how we live, is not binary, and it can be fluid. And this has been true for a very long time. Gender variations are diverse and not abnormal. So the whole concept of, well, what does non-cisgender mean if you're not transgender? Well, some people are on their way to figuring it out. Some people are just trying something out. Some people really prefer to live in a world where they are not one or the other because it's more comfortable. We know that gender in itself is very, very complicated. And so even though I understand what a uterus is, and that seems pretty simple to me, and that makes a biologic female, that doesn't necessarily make a woman, much like the absence of one doesn't make you not a woman, right? So gender is an intersection between a lot of different things, and it's really important, but we ascribe a lot of importance to it that doesn't need to be there. But it's development, it's biology, it's how we're socialized, it's culture, it's context. We understand gender from a very early age. Babies will gravitate towards a female voice. Why? Because it's food, right? Babies at the age of 9 months can start to identify male and female items, which is amazing. So gender is like recognizing gender, and we recognize race, ethnicity too, right? But these are really deep survival things that have nothing to do with living in a pluralistic society like we do today. And the pathology that people experience, the social pathology, the The psychological pathology has much more to do with how people treat them than the gender issue internal to them. Okay, so you have to be able to talk the talk, right? And that can trip you up too. And oh, by the way, in an emergency department, you can be really great at this. But if the person who's registering the patient is not as affirming, your whole exchange is done, right? We always think of ourselves as individuals and being physicians who are really great at talking to people, but people experience us as a system and as a visit. And so anyone in that system can mess it up and destroy trust. So scripting is really important, especially if you don't do this all the time, right? So what do you say when we script everything? And if it's, a little halting for you, that's fine. I think people care far more that you're authentic and trying than they do that you get it right. Which name and what pronouns would you prefer? Very easy. Just get in the habit. I live in North Carolina. I came from Indiana, both bastions of really progressive thought. And I have a friend who lives in San Francisco, and I talked to her about this, and she's like, Emily, this is so 20 years ago. Like, okay, San Francisco, for you maybe, but over here, we're just learning how to do this well. All right, so talking the talk, making sure it's an affirming. You are Stephen. Hi, Stephen. Right? That is gender affirming. Now, we're not primary care providers who talk about whether or not we're going to refer you to a gender clinic and get you started on the hormones or the hormone blockade, and we'll talk about the medicines right now. But at the very least, we can just meet people where they are. Okay. One of the biggest concerns that people have is, what if this is temporary, right? Adolescence, which, by the way, goes into your mid-20s, is all about trying to figure out how you fit in the world, where you want to be, what do I want to be like, who do I emulate, right? And you try on a lot of different hats. Thankfully, we lose a lot of them, right? Because a lot of the things that we thought were really cool then are just not sustainable. So how do we know when youth are persisters versus desisters? Most children, most gender dysphoric prepubertal youth do not end up being gender dysphoric adolescents or transgender adults. This is a normal part of exploring the world. And oh, by the way, maybe if we did a better job at having less rigid boxes around genders, this wouldn't be so dysphoric, right? Because I don't think, again, most of us live in the middle anyway. So what makes people persisters? And for us, it doesn't really matter because we're not going to be prescribing a lot of the medicines, but just if you have families who are going through this, or you have a suicidal adolescent because all of this is going on, it's overwhelming to them, knowing this is really important. Persisters have a higher degree of dysphoria. I have a friend whose daughter is transgender, and she knew at the age of 3. And she was adamant that you can't, she was very distressed by the fact that she had a penis. This was terrible to her at the age of 3. And it went on and on and on. She socially transitioned when she was 8. I would probably guess that she will go on to continue living as a woman for her life, right? But it's not always that simple, right? Sometimes it starts at 10. Sometimes it starts at 14. And then you think, well, is this suggestivity? Is this social pressures? And I would say that despite how much we talk about it and how glamorous it looks on Euphoria, being transgender is still probably a pretty tough road to navigate, even in 2022. And so if you're exploring this, there's something here. Now, it might not be that you end up being a transgender adult, but there's something here to explore, to say, hold on a second, we need to talk about this, we need to figure this out. The challenge that I have as a parent is that it's not a quick, is it strep or is it virus, right? That's what I want to know. Are we going through this? Are we going down this road or are we not, right? Because that's what you want to know as a parent. You're like, this is going to take years. Who knows? Which can be very stressful. But at the end of the day, they didn't have to say, well, why? Why is that so stressful? If you have undergone a social transition and you've gone through the stress of doing that, again, we are wired for belonging and connection. So you are doing something that, even though it's more socially acceptable, is still a big jump. You're probably more likely to persist. And if you believe you are rather than wish you were, that's very different too. So there are clues that say this is more likely to persist, but there's no strep test. Sorry. The reason why it gets really important is that there's a time clock here that matters to some people who are transgender. Not every human being who is transgender wants to go down the hormonal adjustment trail, okay? But for those who do, you have a small window. So if I'm growing up and I'm a transgender male, the last thing I want to do is get hips and breasts and female adipose deposition, because it will mean that my potential to be able to pass and to just live a normal life as a male is markedly reduced no matter what I do. No matter what body modifications I do, it's still going to be harder to pass. And so there's something about this age group, which is young. It's young. And so we get nervous. And we should get nervous because it's children and we don't want to screw it up. So I'm not a science person, so this is my science part of the... I love science. Okay, you have a brain that has a hypothalamus, and it releases pulsatile GnRH. And that pulsatile GnRH acts at the pituitary to release LH, FSH, which then acts on your gonads in the male's interstitial cells, in females' follicles and tubules. You get testosterone, you get estrogen, right? I'm sure there's a lot more. I'm sure an endocrinologist is hitting themselves on the forehead right now, but that's the ER doc. That's about as much as I can take from an endocrine perspective. So what if we block it? What if we block this whole system from happening right about the hypothalamus? What happens? Well, that's what we do. That's the puberty blockade that people get really excited about. And they get excited about it for a good reason, that we don't like to medicate children if we're careful. We should be careful. But if we give people GnRH, we can block puberty from happening. We do it all the time. We have children with precocious puberty. We give them GnRH analogs all day long. We've been doing it for decades. We prescribe hormones all the time. We prescribe prednisone, we prescribe insulin, right? We prescribe hormones. So if you give GnRH, does it work? And this was a study that came out 2 years ago, and really, from my perspective, I tend to be a pretty pragmatic person, makes a lot of sense. They did a cross-sectional study of over 20,000 transgender adults. 45% were assigned male at birth. Of that, these are important pieces to think about. Only 17% wanted pubertal suppression. So even people who are adults who identify as transgender, less than a fifth of them would have pursued hormonal modification. 2.5% received it. So of the people who said, oh my gosh, that would have made such a huge difference in my life, a very small group got it. If you wanted and received pubertal suppression, your associated odds ratio for suicidal ideation is 0.3 versus those who wanted it and did not get it. And that's high stakes, right? Because we know that adolescents are at higher risk for suicide. Half of them think about it at some point in their lives. Lots of kids try it. And we're trying to save lives. I mean, right? Is gender really worth ending your life? Like, are we so excited about how we express ourselves that we put people in a place where they feel suicidal over it? So there's something here. Do we know the full answer? We don't. We don't know the full answer. But there's something here. And that something is, if you feel like, if even an adolescent knows that if they feel like they need something, they probably need it. And there are lots of children who are going through this who don't want it. And I guarantee you there will be children, if we continue on this path of being more affirming and doing these things and hopefully helping children see that gender is really, like, it's just a thing about you, and if you want, fine. There are going to be times where we get it wrong. We do it all the time. We get things wrong all the time in medicine, right? How many people do we kill with medical mistakes every year? How many times do medical clinics go crazy and prescribe medicines even though they're not warranted because it makes them money and it keeps them going, right? That's going to happen. The challenge is you've got a group of people who are 4 times more likely to commit suicide and twice as likely to live in poverty. That's a lot of risk. And so you've got to weigh these things, right? But there's no panacea. So how do you ask? Because I guarantee you, whether adults or kids, you're going to ask about hormones, and you got to be able to ask, and you got to do it really smoothly, or they're not going to tell you. If they don't feel like it's a safe place, they are not going to tell you that they're doing T to be more male. So, are you taking any hormones or medications to help you with your gender expression? Very simple. Now somebody will tell you the truth about what's going on. So we block puberty. We do it with GnRH analogs. Normal GnRH is pulsatile. If you give it in a sustained fashion, you block LH and FSH. It's either injection or sub-Q, very low side effect profile. We've been giving it for a long time for precocious puberty. It's a wonderful drug. And what it does is it pushes a pause button so you can gain more information. Like, let's just hold off. We wait for puberty to start because some kids start puberty and they say, you know what, actually I'm okay here. I'm gonna keep going. And some children, it causes such dysphoria and such angst that you're like, please, can we just pause this for a second while we get more services wrapped around, get more conversations. It is reversible. You could take it for years and take it off and body goes right back on a pubertal train. The challenge is it's about $1,600 a month. And you have to start it early in puberty. Not a lot of people are ready to do that. So there's some disadvantages too. But there are some people for whom this is a great candidate medicine. And of course, for those who are underinsured or uninsured, it's almost cost prohibitive, which just makes life harder down the line. So what do we need to know as ER docs? Very little. They might have an implant for this and it can get infected. There's a very low risk of some organ dysfunction, but if you're on this medication, you're getting followed. And there are really no hormonal repercussions. Is there bone density issues down the line? Yes. Is there growth retardation if we put someone on chronic steroids for their asthma? Yes. Right? We live with these things because we think the benefit outweighs the risk. For those who can't afford GnRH, you can use progesterone. It does suppress gonadotropin, has a mild anti-androgen effect, so for trans females, that can be very helpful. It is not as effective, but it's much cheaper at $30 a month. Spironolactone is a common medication you'll see. It's an oral anti-androgen, and it blocks testosterone. What's really nice about spironolactone is that it's not as effective at blocking testosterone, but it blocks DHT, which causes unwanted facial hair. Doesn't work as well once facial hair is already developed. So for trans females, GnRH is much better because you don't get the thick follicles that you then spend the rest of your life trying to remove. It's good for later puberty, and it does lead to some breast development, which whichever trans female you would prefer, and it's much cheaper. Norethindrone is another medication that people will be on. It will induce amenorrhea. You take it orally, but it is less effective. So what do you do if the puberty train hasn't left yet? Honestly, the goal, like if in an ideal world, if they wanted it, and if it was perceived to be a good course of action by a bunch of medical experts who do this for a living and that you presumably trust, GnRH would be a great way to go. There are some other options that are more cost effective for people who can't afford it. But that doesn't really help you once the puberty train has left, because now, or once you've decided that you're going to start transitioning to the other gender. And so then at that point you need either masculinization hormones or feminization hormones. Masculinization hormones are testosterone or T. It's transdermal, subcutaneous, or IM. It can cause cystic acne, and polycythemia are really the big problems with it. Otherwise, it works very well. There are some things that for screening purposes that can be affected, but again, that's not going to affect us in the emergency department. And for peripubertal young adults, that you continue the GnRH, because then you don't have to take as much testosterone to get the effect that you want. Feminization hormones, first you have to block testosterone secretion and action. You do that with spironolactone, like we talked about earlier, or finasteride, which is a 5-alpha reductase inhibitor, which prevents testosterone from going to DHT. You don't care about that normally, you remember it, but it's a good blockade of peripheral action of testosterone. And then you take estrogens, and again, to the victor goes the spoils if you have access to insurance and and good medications. You'd probably want to take 7-beta estradiol. It's a very natural estrogen. You can follow levels because it's the body's natural hormone. So labs are easy to obtain. You have a less risk of thromboembolic events with 17-beta estradiol than you do with the conjugated or synthetic estrogen. So that would be the one you want, and you can take it transdermal or parenteral for feminization. So, and most people stop there. Most people stop there. Because again, when we think about our gender is so complicated, right? But most people want to be in the world like the gender they feel, not like the gender they don't feel. And so they want to present or appear to be. That has nothing to do with your genitals, I hope. I hope your genitals are not out for people to determine whether we keep those tucked in. No pun intended. Surgeries are not pursued by all individuals. In fact, very few individuals pursue surgeries, especially bottom surgeries. Don't ever use terms like, are you pre-op or post-op? Because there's no op. Like, you might have a surgery, you might not. Top surgeries are more common than bottom surgeries, so you're gonna have to get really comfortable about asking people what surgeries they've had, or what have they done to help them get the body that matches their gender, the presentation they want. And then mastectomy, obviously, for trans males is pretty common because it's nice to wear a bathing suit sometimes. We like to swim as humans, and so most trans men like to get top surgery so that they can do that. Vaginoplasty and phalloplasty becoming far more common, and there are some complications to think about if you have patients that come in after these procedures, and just special things to think about with this patient population, but they're less common. What is more common is just sort of getting by, right? So there's tucking and binding. And tucking is not just tucking the penis and scrotum into the gluteal fold, it's also pushing the testicles up into the inguinal canal. So you get a feminine front if you wear a bathing suit, right? Or you wear tight-fitting clothes. You don't want any bulges that would give away that you're not a cis female, which is fair. The challenge with that is that it causes a lot of local trauma, and it can cause some orchitis, and you can get recurrent urinary tract infections from it. So if you have someone who's tucking, it's really important to talk to them about it. And the goal is there's not much you can do about it if that's something that they feel they need to do, or if the presence of their genitalia is causing them problems and that's just what they do to feel good about their life, is try to do it as minimally as possible, right? Only when you need to. And then binding is what trans men do to hide their breast tissue, where you bind really tight. And you can get a cellulitis and some pretty nasty skin breakdown from that if you're doing it all the time. Now again, if you ask, you gotta be pretty comfortable asking someone about this, right? We have uncomfortable conversations all the time, so it's not a huge deal, but you gotta be comfortable more important than you need to be comfortable, you need to be so comfortable that the other person feels your comfort and will let you take down that binding so that you can see if they have a nasty cellulitis that they need to take care of. Okay, pumping. Pumping is something else we do because, why? Because medical community hasn't caught up with the social community on how to do this, right? So you go to non-physicians to get the body that you need. And so pumping is silicone injections. It's usually given by non-physicians in non-clinical settings. And it does a really great job of giving you hips or a larger rear or whatever it is that you feel would make you present more in the gender that you identify with. The challenge is it's just loose silicone, unlike breast implants where they're encapsulated in a case. It's just loose silicone. It's usually cut with other things. It's unfortunately more common for people who have less access to care or less trust in the healthcare system, as you would expect. But it has its own challenges. So if you need most surgeries are rejected by insurance, so you need a lot of money to do the things that some people feel they need, even from a standpoint of hormones. So there's a lot of sort of black market other ways that people get this. So it's a liquid, it can get infected. We had a young woman in North Carolina who was getting silicone injections into her hips, and she died of a massive pulmonary embolus in a clinic because it got injected to the bloodstream. It also settles and it moves. And so it works really well for a year or two, can be very disfiguring, and there's nothing you can do about it. And it can become like concrete. So if you're sitting outside on a cold bench, it'll literally become like concrete. And it's temperature sensitive. And it's usually cut with other things that are just horrible. So it's a problem, but it's sought after by need. And then you can get acute silicone syndrome, which from an emergency department standpoint can look very much like COVID or pneumonia or anything else under those guises. It happens hours to days after silicone injection, causes all the things that make us think that it's an infection of the lungs. The chest x-ray looks like COVID, and you can get consolidations, all kinds of things. If you don't know that they've injected, you might not make this diagnosis. Steroids are fundamental to this, and you can usually support people through it. For some reason, it's not a permanent state, so you can support people through this, but you do need to know that that's the cause. Okay, so then what people have this strange fascination with is the surgeries, which is so fascinating. Think about that tonight. Why are we so fascinated by this? But we are. So if you're going to get a vaginoplasty, so first of all, if you're seeing a trans male or a trans female in the emergency department, you have to understand that any examination could be fraught with some tension. Not always. Some people, super comfortable. They don't care. But many people are not, though. So figuring out what organs they have, what language they use to describe themselves, their genitals, can be helpful. For some trans males, especially young trans males, having a period is very troubling because it's just a reminder that you're not where you think you are. Vaginoplasties, so then you get all the way to the vaginoplasty. Vaginoplasties are much more common than phalloplasties, but both are becoming more common. So vaginoplasty involves a lot of surgeries. It's an orchiectomy, a penectomy, vaginoplasty, chloroplasty, and vulvoplasty. It's a massive surgery. And you get a neovagina that's usually made out of a penoscrotal flap, a reconstructed rectosigmoid colon, or peritoneal lining. There's advantages and disadvantages to any of these methods, but they're all used. And you can imagine that if you have a penoscrotal flap, it doesn't have the same pH or moisture environment that, for example, a retrosigmoid colon would, but the retrosigmoid colon is a secretory space, so then you have other issues that you're dealing with. When you get the surgery, you get the neovagina is built 6 months, then it heals and works pretty well. After the first week, if there's a problem, post-op problem, you can do a pelvic exam carefully. So only if you're using the orange dilator can you use a normal pelvic speculum. Otherwise, you need to use a Peterson or an anoscope to see what the problem is inside. And obviously, painful and traumatic, so lots of care. Some even suggest that you might need to offer something sedating for this exam, but not out of the range of what we should be able to do in the emergency department. You can get a urinary retention. There is zero problem putting a catheter in a vaginoplasty patient. Nothing was built around the urethra. The urethra is just made shorter, so you can still place a normal catheter. Check a post-void residual. They still could have scarring and swelling that causes urinary retention, so you may have to place a Foley, but don't panic about placing a Foley. You're not going to cause harm. It's not like a different kind of urologic procedure where you need the urologist to come and place their catheter. Antibiotics and follow up. And then UTIs and STIs are the same as any cisgender female. Cultures, antibiotics. So after the treatment is done and they're past healing, the biggest issue they have post-surgically is some wound dehiscence, and that's not managed by anything miraculous. That's just a lot of what we normally do for wound dehiscence, and it can usually heal up on its own. Bleeding, you can get pretty impressive bleeding if you have a hematoma. You can get a little bit of bleeding from granulation tissue. It's very rarely heavy. It can be if you have a hematoma early on. You can use TXA. You can transfuse if needed, but that's very, very uncommon. Discharge is not as uncommon. Always check for an STI. Wound infections can happen. Bacterial overgrowth, again, this is not the normal vaginal environment. This is different tissue. So it has a different pH. You can get different issues. So if it's not being cleansed regularly, you can get bacterial overgrowth. And everything else, even if they have some necrosis or a fistula, that's outpatient. It's not an emergency. So don't be nervous about these. These are just, you can just arrange follow-up for these patients. Post-operatively, these are significant wounds, and so they can get all the normal things that you get after surgery: cellulitis, abscess. You can get tissue necrosis. Necrotizing fasciitis is very rare unless they have predisposing factors like diabetes. But dehiscence is pretty common, up to 1/3 of patients. So that is something you could see. But again, heal up on its own. Don't put ointments, creams, or dressings on it because that'll increase your likelihood of getting a worse infection. And they unfortunately, if they don't want it to close, they're going to have to continue dilating even if they have this happening. Transmasculine surgery is interesting because there's two different kinds, and this is relatively new. There's metoidioplasty or meta or phalloplasty. The meta is much easier to undergo and has a much better result. And that is where you clip the clitoral ligament, and then with testosterone you get clitoral enlargement to the point where you get like a microphallus that they can make appear. And so for some people, it is the act of standing up to urinate, like to go into the men's bathroom and stand up to urinate, that makes a huge difference for them. With the metoidioplasty as well, you have some sexual function with that. The phalloplasty is a much bigger deal, and sexual function is much harder, so not as many people go to that step. If you have either of these, if there's urinary retention in this case, that's a bigger deal, and you're going to need a urologist. The recommendation is to try a 12 or 4 French coude tip, but I would say if I decide a fresh post-op meta or phalloplasty, I probably would talk to somebody before I instrumented that at all. You can get necrosis. This is a big deal because obviously it's like a failed graft, right? It's usually in the first 48 hours. They're going to need urology and plastics, and that's emergent. Infection can happen just like any other surgery, and that's usually not an emergency unless they're sick from it. The donor site, you always have to check the donor site too. Phalloplasties are done from different donor sites. Sometimes it's done from the inside of the medial thigh. Sometimes it's done from the skin on the arm. So you just needed to make sure that if there's a fever post-op, you want to make sure that you check the donor site for the tissue. That's awesome font for you all. I hope you can all read that really well. WPATH is the World Professional Association for Transgender Health. There are so many resources for these things, any questions you have regarding emergency care or preventative care or just how to be supportive. WPATH is really good. Fenway Health is another really great resource for healthcare providers, and the CDC has a lot of information as well. So in conclusion, of all the things that we talked about, the most important thing is to not pathologize gender fluidity. It's always been part of human cultures, and it always will be. We have to know how to ask the most basic questions in a way that makes people feel vulnerable or comfortable enough in a vulnerable state to tell us the things that we need to know to take great care of them. And then always understanding the importance of pubertal blockade for the few patients who want it and need it. I'm happy to answer any questions. And if you do have questions, I have a gift. It's not my gift. So if it's a terrible gift, it's from Mike Bond. If it's a wonderful gift, Emily MacNeill.
Any questions? Rachel?
So you mentioned that the emergency department is a visit as a whole to patients, and I think that's something that a lot of people have seen throughout a variety of patient complaints when it comes to a bad experience in the emergency department. How can you work to get your entire staff on board and to provide appropriate education for staff members of different levels with different levels of healthcare knowledge?
Well, thankfully, the electronic medical record is helping us a lot with that, so you can get SOGI information, sexual orientation, gender identity information. I mean, I feel sometimes like I have more information about the gender identity and sexual orientation of the 10-month-old that I've just picked up than I do whether or not their mom had GBBS, right? Like, there's just it's fascinating how fast this is going. I'm like, well, this is a lot of information. on little Sally. So I think that helps because now when people are asking questions and it's just part of our cultural milieu is much different. I think scripting for people is the best way to do it because that way it becomes mundane because it is kind of mundane. I mean, it's not really that exciting, right? It's just gender. So scripting is huge. And then, I think the culture of an emergency department, it should always be that we don't have a patient panel. We have a community, and it's everybody in that community, and everybody in that community needs to feel safe and cared for when they're here. And so it's whatever they need, whenever they need it, right? You get a mouse.
It's probably the reality that
most people, and I'm self-admitting here, I only think to ask these questions based on my own judgment, which is really a poor approach, because we should be asking really everyone, because we shouldn't leave it based to our own assumption of how someone appears. Right, okay, so this is probably the reality of I think where most people are, but I can just speak for myself. Will it be a law or policy one day that we will have in the EMR gender biological and then gender preferred?
So yes, and our healthcare system has that all epic, they all have the option to do it. Whether or not your health system embraces that, puts that in is another thing. But so on all my patients, I know their sexual orientation, gender identity, their self-described race, ethnicity, all of that information, because that's a push.
should be required everywhere.
Should be required everywhere. And it's just part of like a normal social history, past medical history, because then it's not, I think it's very culturally dependent too, and that's okay, right? Again, we don't all have to be the same from culture to culture, but if you go to San Francisco, they start we start every meeting with our gender pronouns. I was like, yeah, I don't think that would go so well in Charlotte, right? So I put it on my email, like, hey guys, let's think about this. So it is very dependent on where you are and where you practice. But I do think, and so I do the same thing, to be honest. I look and see, but I kind of try to assess the situation. And that's not great, but I don't think we're at a place yet socially where we present that way. And so some people do other things so that if you do, a lot of my work in D&I is the don't be a donkey, is like my general, just don't be a donkey, like be a good human, like you want to be, and like you woke up this morning thinking you would be. Like let's all do that for each other, shall we? And so people don't really care if you step in it, right? Like if you step in, like if you say something that was off, what they care about is how you respond to when it's brought to your attention. That is what gains or kills trust, from my perspective. And so, if you step in it, if you don't say it when you should have, and it happens to me too. I give this lecture, and I took care of a young man who came in with abdominal pain, and I scanned him, and he was not a biologic male, and I was like, well, good job, Emily, great. Like, maybe I should have asked. But it's hard. It's not yet part of our everyday like it is to say, do you sleep with men, women, or both, right? Which is now so easy for us to ask that we do it every time we take a sexual history. And maybe weaving it into the sexual history is what's appropriate. Not necessarily for adolescents, because that's a little bit more tender. But you can still ask those questions. How do you feel most days? Some people feel like the way they look, and some people don't. Where do you feel, like a boy, a girl, or sometimes you don't know? And I would guess, I'm not trying to get into everybody's brain here. At some point during adolescence, you're like, what is this? Who am I? Where do I fit in? Right? It's just part of being a human, trying to figure it all out. But again, I think part of sexual history is probably the best time if you haven't figured out a way to do it elsewhere.
Just a comment, Emily, wonderful talk, thank you so much. And I just want to highlight also, great question from Whitney. And as Emily said, identifying your own pronouns, whether that's when you first approach a patient or in your email or whatever, I think is very helpful to open the door. And, aside from whether your EMR system supports gender identification per patient or not yet, I think, it's an easy step, and a lot of places have like name badge buttons that say what your own pronoun is that you can, wear proudly, and the patient immediately seeing that can be like, okay, this person's like good with this. I can share my and feel more comfortable sharing, my true being. So just a comment on that.
Yes, and also don't tweet about it if something goes awry with that button, as we've learned over the last few weeks. The other thing, too, is that there's lots of people who mistrust us, right? And a growing group that mistrust us are people who feel left behind, either socially, economically, and it can be people who struggle with this idea. So sometimes wearing that button can be a clue to somebody else to say, if you don't agree with me, you don't belong here. And so it's, if you're going to be inclusive, it goes in all ways, and you just have to be really aware that, but we can do it. Like, we can all live together in harmony. And that's where I turn off.
Well, thank you very much.